Welcome to the latest edition of Let's Talk Blood Cancer, the Patients Podcast, hosted by me, Adam Joyce, former blood cancer patient myself, and now proud patron of Leukaemia. And joining me on the sofa today, out of his incredibly busy schedule, Professor Rob Wynn. Welcome. Rob is a consultant paediatric haematologist and the director of blood and bone marrow transplant at Manchester Children's Hospital. Rob, first of all, thank you for taking time out of your day
Thank you for asking me.
to come and see us today. Rob, I'm really keen, first of all, to learn about you. How on earth did you end up in the role that you're in now? Tell us about your early life.
Well, I'm very lucky to be in the role I am now, and I'm very grateful. So I'm from Liverpool. I'm not from a family of medics. In fact, my dad suggested that I should not do medicine. He thought it was a very dirty profession, lots of living in the gutter, he called it. But I remember at school when first day of sixth form, the teacher said, "What are you all going to do?" My name is Wynn, and that means I was the last to have to answer. And for the first time, some of the other kids said they were going to do medicine, and then I thought, when it came to my turn, I said medicine. So I was lucky to do medicine. It wasn't something I thought of till that moment. I went to
So you'd panicked because the other kids had said
I'm not
medicine?
sure it was a panic, but I was doing sciences. My brother is a year older than me in school, and he's now professor of philosophy at Oxford. So he was in a different style of life. Very clever fella, and I did sciences. And so I ended up in a science class in sixth form, and that's where they asked us what they were going to do. And I honestly had no idea what I was going to do until the other fellas said medicine, so I said medicine. And then here I am. So I went to Cambridge, and then I went to London, and then trained in medicine. I always liked haematology, so it was very well taught in the hospital I was at. Very good doctors, very caring doctors, and they combined the science of medicine and the philosophy of medicine, so looking after patients, talking to patients. And so I ended up in haematology. And then in children, I did adult medicine to begin with. My wife is a pediatrician, and so I switched to pediatrics quite late. So I did some adult medicine, then some children's medicine, then some haematology. And I've now been in Manchester for 31 years.
Wow.
Most of the time as a consultant. And again, of course, because I'm from Liverpool, the very last place I wanted to end up was Manchester. And so it's been a hard 31 years, especially as Man United, for most of those years, have been much better than Liverpool. But the last few years have been good.
Well, we'll pick up on the football and the rivalry shortly, Rob. But I mean, you've summarised a long time there. Was there a defining moment for you? You've said that you had that interest in haematology. So was there a defining moment, first of all, for haematology, and secondly, for you to focus on paediatrics?
Yeah, so haematology came from medical school. I was actually going to be a psychiatrist for a while. I thought about doing psychiatry. I did my elective in Chile in psychiatry. But there is a lot of psychiatry in haematology. We spend a lot of time talking. A lot of what we do is about talking about disease, explaining disease. And then there is the science next to it. When I have medical students or people that want to do haematology, I say that there's more than one aspect to it. There is the medical aspect. You have to be, I think, a good doctor to do haematology. You'll know from your experience, lots of bits of you can get sick when we're treating blood cancer. So being a good doctor is important. Being a good communicator is important. Talking to families for us, talking to children, talking to other colleagues. And then next to it, again, the third thing I would say is the science of it is that we're lucky that we can be part of the change of medicine. And in the 30 years I've been in Manchester, the outcomes for the kids are radically different. The treatments that we give are so different. The genetics of the disease, understanding the genetics, targeting molecular defects. It's a different world, and it's been fun to be part of it. But of course, part of the fun is offering treatments and good outcomes for kids where we didn't have them before. And of course, part of these discussions that we're still not there. We treat lots of kids and we cure most of them, but most isn't enough, obviously, for the child, for their family, and for all of us. And so we've still got steps to take. And just as we've taken steps over the last 20, 30 years to improve outcomes. I hope that we'll continue to take them over the next 20 to 30 years.
Can you remember what it was like early on in your haematology career and some of the conversations that you used to have with families and children? And I guess what I'm really honing in on now is the difference between when you started to where we are now. And then, of course, we can start looking towards the future.
Yeah, it is very different. I think where chemotherapy fails, and that's where transplant comes in, then we have many more options now than we used to have. So if I look at transplant, we used to use family donors and then increasingly unrelated donors out from people outside the family. And one of my interests has been using cord blood donors. And what we see when we use cord blood is that we see a better outcome. So cord blood seems to be better at curing leukemia. And that's mainly, I think, because the cord blood immune system sees cancer cells and kills them.
Well, Rob, I've only got a really basic understanding of cord blood transplants, and I'm sure most of our viewers have as well. Can you elaborate on that for us, exactly what it is?
Certainly. So when we do a transplant, we have the child and we change their bone marrow. So at the moment, for any child on my ward, their blood is made in their bone marrow. After we do a transplant, we give them a new bone marrow. And so the donor bone marrow then makes blood in the patient. So actually, if I looked at the DNA of a child that's had a transplant, if I took their DNA from their blood, it isn't their DNA, it's someone else's. Wow. So we often chat, and the kids find it interesting sometimes that, you could frame your donor by leaving some blood at a crime scene because it's not your DNA, it's their DNA. So we need a donor. And the reason transplant works is actually that the donor sees the patient's leukemia as different. So we give chemotherapy, but if it doesn't get rid of the cancer, we need to change focus and we use a new immune system to get rid of it. So we need a donor. It's usually either a family member or an adult unrelated donor, but we can use cord blood. So when you have your baby, then we can take the newborn baby's blood. We actually take it from the placenta. So the baby is born healthy, given to the mum and the dad, and then we can take blood from the placenta that is otherwise thrown away. And actually that's a bit like a bone marrow. So it's full of blood stem cells. And so if I do a transplant, instead of using a donor bone marrow, I can use that cord blood from a newborn baby. So what we do is it's frozen. It's actually taken from many different hospitals, but one of them is Manchester. So we take, the Anthony Nolan takes cord blood from babies born in Manchester. It freezes that blood. And sometimes we will use that cord blood for children transplanted in Manchester. So it's come from 100 yards down the corridor from the maternity unit, and then we use it later. And the cord blood acts like a bone marrow. So after the transplant, it is the cord blood of the newborn baby that is making blood for the rest of the child's life. So there are lots of advantages to cord blood. We don't have to find a donor. The donor is already donated. The blood is frozen. We can go and get it, and so we can use it quickly. But actually, if we compare bone marrow with cord blood, as we've done in the children's group in Manchester, it seems to be that cord blood is better at getting rid of leukemia. And our current focus of research is to understand why that is. And we've got some exciting data from the patients that we look after, which is that early after the transplant, in the first days after we've done a cord blood transplant, we see the immune system of the cord blood becoming very active. So we've got our child, we've put the cord blood in, and then in those first few days, even hours, we see a lot of immune cells. And those immune cells are what gets rid of the cancer. And so our research in Manchester is to see if we can push those immune cells even more towards the cancer. And actually, we've got a research program where we will vaccinate. So we will take the cord blood, and on the day of the transplant, we will do a vaccine, but instead of an infectious disease vaccine, we'll do a cancer vaccine. So the cancer has different proteins, and we will vaccinate with those proteins so that we can push the immune system towards the cancer in a more specific way. So we need a bit of money to do that, and we're applying for money. But I think this is the way that medicine works. So we make observations as teams, and the observations here are two very simple observations, one of which cord is better. Second is that we get this immune cell recovery early after transplant. And so we look to say, do we need to make it better? Yes, still some kids fail transplant. And can we make it better by pushing those cells more specifically to the cancer? And that's how research works. We first of all look at our kids and say, are we doing enough? No. We're doing well, but not enough. How does our current treatment work? And what are the side effects of that treatment? And so in the next lot of treatment that we do, can we make it work better and have fewer side effects so that whoever's in Manchester or wherever in 20 years' time and sitting on this sofa, they've got better results for the kids that they look after.
Could you have foreseen that you would be at this point now, as we are in 2026, having this discussion when you were at the start of your career? Was cord transplant even a thing back then?
No, I think the first cord transplant would have been done perhaps in the a bit later when I was a medical student in 83 to 89. So no, I think there's a few things to say there. First of all, I'm very lucky. I came into medicine by accident, as I said. I went to medical school and didn't have any real thought about being a doctor. I was doing medicine, but I'm not like from a family of doctors. You know, medical students these days have always done a lot of work experience. I'd never been near a hospital. And so I found my way through medicine and found my way through to haematology and through to paediatrics by chance, to Manchester by accident. So I was a registrar in Cardiff. So we were in Cardiff 93 to 95. I saw a few children there, and there was a job advertised in paediatric haematology in Manchester. And I worked for a guy called Alan Burnett, who's the professor of haematology in Cardiff. And he was a Glaswegian fellow. And I remember going into his office and saying, actually, I want to do children, and and there's this job in Manchester. And I'm sure he put a word in for me. We got on well, and I owe him a lot. And however difficult our job is, looking after children with cancer, I don't regret it for a single day, and making that difference to the children in front of me, first of all. And then because we're busy and we look after kids, it's that we can then ask those questions. Does our treatment do enough? What are its side effects? Can we make it work better? Can we make it safer? And it's such a privilege to have been able to work in a single place, work hard. There wasn't many of us in the early days, and the transplant unit was smaller. It's a big unit now. But what we've seen over that time, better understanding of disease, and what we've seen is amazing. Mm-hmm. So cord blood, wasn't around when we did it. I did the first cord blood in Manchester. Bone marrow transplants got better, but using these fancy T-cell therapies like CAR-T, and the gene therapies. I have a gene therapy program for kids with non-malignant disease, which again is a similar story to the cancer story. So we look at how our treatments work, and in those kids, they're short of an enzyme. And if I did a transplant, so if I was using you as my donor, I'm using your cells to give the enzyme. And what we've learned and worked at over those years is, instead of using a donor, take the patient's own cells, put in the gene for the enzyme, make their own cells make the enzyme, and make it better because you can give more enzyme, but also make it safer. And it's it's been fun to do that over the years. But most of all, I like seeing the kids back on the ward who have the newer treatments that work better than the older treatments, safer or better. And I'm sure that my colleagues will look at the treatments that I've done and say, come on, that wasn't good enough, it wasn't safe enough, you're taking too much risk, or it didn't work well enough. And haematology is always at the edge of medicine, because of the diseases we look after, because of the labs that we're in, because of the people we work with. So I'm sure that this is just a step along the journey, and I hope that kids are cured without the side effects we give them, and that more kids are cured than what we currently are able to do.
It's an incredibly humble approach that I see from you. You've used the words lucky and privileged. You've also used the word fun quite a lot as well. But Rob, what kind of numbers are we talking here? And I'm talking now about patients. I guess the really simple question to ask is, what's the extent of this problem? How many children are you diagnosing, or are we diagnosing in the UK? How great is this challenge that we face?
So for Manchester, then we look after about 1 million children. So from the south, so Crewe up to the south of the Lake District. So the big cities are, Manchester, Liverpool, whatever. And there's about 1 million children in there. We're probably seeing 100 cases of leukemia. So it's not that rare. It's the commonest cancer. And most of those kids are cured. For the transplant program, we'll be taking kids from a bigger region. And the fancier the medicine that you have the opportunity to do, the further kids will come. And that's also good. I enjoy having the French kids and the American kids and the German, Australian patients in Manchester, because that means you're doing something right. And if you've got the opportunity to treat kids from all over, you're learning. It's nice to see them. It's nice to give them the chances as well. So it is a big problem in terms of cancers in children. Cancer is much less common in children than it is in adults. And the outcomes are much better, but there is still unmet need. We're not curing everybody. And I think two further things to say there. First of all, what we learn from treating kids is relevant in treating adults. So much of the innovation in cancer medicine, in haematology medicine, has started in children, and then is applicable to adults. That's the first thing. And the second thing to say, I think, in there is that cancer in children isn't just leukemia. And our results in leukemia are probably better than they are in some other cancers like brain tumors. And what we've learned from haematology in children is not just relevant to haematology in adults, but to these solid tumors. So what we've learned is that you can use cells to cure leukemia. So I've talked about bone marrow transplants. So the reason our transplants work is mainly because the new immune system rejects the cancer. And we're talking about blood cancer. But we can use cells to cure solid tumors, brain tumors. And I think that is an area where we're going to see a lot of change in these next years. So we've learned, actually for 50, 60 years, that a bone marrow transplant can cure leukemia. We've learned that the transplant can cure leukemia because the cells of the donor see the leukemia. So when we look at my cord blood work, it's the cells of the cord blood that see the leukemia of the patient. And we're seeing this early immune response after cord blood transplant. And I've talked about our vaccine program, or what we're trying to do is, we know we've got cord blood immune cells very early after the transplant in a patient with cancer. We know that those immune cells get rid of cancer. That's what CAR and things like that are. So if we've got these immune cells early after transplant, can we push them to kill the leukemia? But maybe ask another question. Can we push them to kill a brain tumor, or to a young woman with breast cancer or melanoma? These are all cancers. They all have unique proteins, and they can all be killed by an immune system. The reason most of us don't have cancer is because our immune system finds it early and gets rid of it. So I think one of the attractions for me looking forward is to see what we're lucky enough to have cured a lot of kids, and we know how it works. We're beginning to understand better and better how it works. And part of that is to say, if it works here, can we make it safer? But if it works here, could it work there? Could it work in another tumor? And in our gene therapy program, we're putting genes in for different genes of different diseases. So if it works in that disease, maybe it can work in this one. And all of what we're trying to do always is to give kids back their lives, so that they can grow up as if they never had cancer. And when I look at the solid tumors, I've always been interested that observed that when leukemic kids are struggling to be cured with chemotherapy, they walk downstairs and they have a transplant. So when chemotherapy and current treatments fail, we switch gear and do something different.
Yeah.
What I see for the solid tumors is that when chemotherapy fails, there are far fewer options. They haven't had transplant before. And so when treatment fails, they go to Disneyland and live their life as best they can. And so it's right for us to ask, even though we're talking cure leukemia, is can we use what we've learned in the transplant unit in curing leukemia, not just to make our leukemia treatments better, but to extend their role and offer them to adults and children with solid tumors. And it's not just me thinking that. There are lots of solid tumor immune therapy programs now. Our one might be focused on cord blood, but there are CAR T therapy, other T cell therapies. And when we look at, the last 30 years of our medicine, I think the next 30 years will have this story as well.
Rob, what are some of the common misconceptions about children with blood cancer that you may be aware of?
I think, first of all, it may not be known just how good our results are. And so when I'm talking here, the first thing to say is that the vast majority of children with blood cancers are cured.
Do you say that to the parents on those early conversations? Yeah.
So I have I think when you're first meeting a family, one of your first responsibilities is to give hope and truth. But the truth is, most children are cured. And so for however many times I've sat on a ward with a newly diagnosed child over the last years, the vast majority of those kids are cured. And what cure means is they're alive, they're well, their disease is gone, and they have no long-term drug need or no long-term side effects. So they can forget that they ever had leukemia. And that's a reason for hope. And so I think that's the first thing, is that our results are good. Much better than in adults, much better than they were in children, and with fewer toxicities and better treatments. So that's the first thing about blood cancer, is that we cure most of our kids. And when we talk about new treatments, for the vast majority of kids, they're not going to need any new treatments because they've got the old treatments that work, and they don't have many long-term side effects, so life should go on as if they never had the cancer. So that's the first message. The second message, I guess, is that there are lots of different types of leukemia. So there isn't just a single type of leukemia or blood cancer. There are lots of different types of leukemia, and different types of leukemia have different treatments and a different prognosis. And within that big spectrum of childhood leukemia are some where the prognosis is less good, they respond less well to chemotherapy or to transplant, and where life expectancy is still limited. And so it's in that area where we need to improve our outcomes. So I think when I look at treatment and its future, the two bits are making it better so that fewer kids die of leukemia, and making it safer so that there are fewer complications and that life is more normal afterwards. But for most, we're okay. We're not bad where we are. They are cured and without long-term side effects. And I'll often say to families that I use the school gates test. So you've got a 2-year-old who's got leukemia. What does our treatment look like? And so the school gates test is you're standing outside the school gates and your kid is 13, 14, 15. They're coming out of school with their mates. Can you tell that your child had leukemia or transplant? And for the vast majority of the kids we look after, you can't. And that is what families at the beginning of a journey or halfway through a journey or when there are difficult moments need to remember. I've seen many, many sick kids in the middle of transplant at diagnosis for whom they pass the school gates test with flying colours in the end, even if there are, dodgy moments along the way. And for our future, it's so that everyone passes that test, and the tests that come beyond it. And that must be our ambition, to cure without toxicity and to cure everyone without side effects.
You said, Rob, that your first responsibility is to give families hope. Is that always possible, or can you find hope in every conversation?
My responsibility is to give hope, but also to give truth. And the truth is, we do not cure all kids. And if and when I know that, then the child is the child of a family, and the family need to know that. So truth is also important. And some children die of leukemia. But I've seen many families, even when we are not able to cure, deal with that with fortitude and with love and with fun and with children that are going to die of disease. That is not what we want, but truth and hope go together in our conversations. And the truth is, of course, here, most kids are okay. But the truth is, and that's why we're here, is that not all kids are okay.
Yeah. And I'm almost reluctant to use the word easier, but does it get easier to have those conversations with families where there are no more treatment options?
We don't have so many of those treatments, so we have so many more treatment options. So, in the years that have gone by, when kids relapsed after transplant, so they had a transplant, the disease came back, we had very few options. These days we have many more options. But it's never easy when you haven't got a curative option for a child. But life is nicer for having many, many treatment options, so that even when transplant fails, we've got different ideas and different ways through.
And you've given us a really good insight into the positivity that you can give and that hope. But how do you explain those complex treatments or the journey that may be ahead of a child without the fear factor? Is that something that you've just learned to do over the years, that you've mastered, or you've sat and practiced?
I think it's a very good question. I think families are resilient, children are resilient, and it's a journey that we take together. I think if you give a list of complications and side effects of treatment on the first day of a leukemia journey, I'm not sure that you've done your job very well, because they do sound scary. They sound scary to me. And in fact, if you take them out of a situation, they are scary. They sound difficult. Within a situation, my experience is that families, children manage, and we get through very difficult moments, but we get through those moments together. It's not easy. It's not where anyone would choose to be. But the reality of it is that is where some families are, where they have to be, and where we will navigate a way through together. And in most cases, we will navigate a way through and we'll make it where we want to be, which is cured and no long-term side effects. And families and children, where they're old enough to understand, are able to do that. And we're able to do it together.
I think I know what you're going to say to me now, but do you take this personally, Rob? How do you protect yourself from what you see, what you have to deal with on a daily basis, and protect yourself from not being part of that family's journey from an emotional point of view?
It's a very good question. So first of all, we're in the business we're in because usually we get through, and so there's a lot of immeasurable rewards in what we do, and we're very lucky to be part of that. Part of the current success and part of a research program that offers future success. So that brings its own rewards. But we all take it personally. We would all want the outcome to be perfect every time. And, the promises that we make to families, that I make to families, that we'll make the right decisions, firstly. I make 3. we'll make the right decisions, so which treatments and whatever. And the second is we will always do our very best. What happens to their child is very important, and we will do our best. And the third thing is that we will always tell the truth, and we won't hide from them difficult moments. And the reality of this is that today I've come here from the hospital in Manchester, and there were some very, very sick kids that I've left behind. And we've had on the wards there, kids with complications of treatment, kids with cancer that shouldn't be there, that hasn't responded, kids with infections. And, when I'm going into work in the morning, I don't have any pleasure that that's what I'm going to see. But that is our job. And if we discharge those responsibilities, making the right decisions, doing our best and telling the truth, that gives us a way of getting through those days. And in the end, though, I'm very lucky to do the job, that I do. I look back at what I thought I might have done in medicine, and I look at what some of my friends that I qualified with, and, thank goodness I'm not a whatever, I won't say what they
you
are.
Attempted.
But, I'm very glad to be a paediatric haematologist and have the chance to cure kids and give them back their lives, and have the chance to participate in research programs and in trials that might make a difference.
What do you do to decompress, Rob? What do you do for yourself that is completely unconnected to looking after others?
I have a family, got 3 kids. I'm a Liverpool fan. That takes a lot of emotional energy out of me.
I was going to ask things that are not emotional.
And I cycle. So I'll get on the bike and cycle 100 miles or whatever.
You do cycle, actually, don't you? Because that takes me nicely onto your cycling that you have done for Leukemia. And there's some certain irony here, isn't there? Because you have done some fantastic fundraising for our charity. The first thing really that I'm sure many would agree with is that you shouldn't have to. And we're taking you out of your busy clinic, or you're taking yourself out of your busy clinic to raise vital funds. But you did have an experience riding the Tour de France, didn't you? Which didn't end perhaps exactly how you wanted it to end when you, you tell us the story about your elbow.
Yeah, well, of course, you should always watch where you're going when you're cycling. That's an important thing. And those of us that cycle know that without always knowing why, you can be on the floor very quickly. And we were going through, I think it was second or third day of the Tour de France. It's important we did do the Tour de France, but we did it slowly. Obviously, we did it exactly 1 week before the professionals. So we did the same course, but a bit more slowly. So we'd be there were some very long days on the bike.
Don't let the truth get in the way of a good story, Rob.
And the second or third day, we stopped at I think someone crossed the road. We were in a group. The group stopped. I was at the back of the group. I didn't stop, or not quickly enough, went over the handlebars. You'll know as a cyclist, the commonest injury when you fall off is you break your collarbone. So I knew my collarbone was okay. But I also knew my elbow was very sore. And I also knew it was broken, it was swollen, and it was painful. And I couldn't sleep most nights because it was so painful. But we agreed that it wasn't broken, and I carried on. It wasn't too bad on the bike itself, actually. And then I had an X-ray when I was back, and I had a fracture of the radius there.
So what's that, 18 days of cycling with broken bone?
Yeah, the main thing was the pain at night. I was all right on the bike, but at night it would keep me awake.
And you didn't quit because you needed to raise funds, we needed to raise funds.
I didn't want to quit. I'd done a lot of training, but it was fun, the Tour de France. So I did do it to raise money. I did do it to raise awareness. I do believe in the cause, but I also had a lot of fun. Cycling in France, we started in Spain, through the mountains. It's a beautiful, a wonderful opportunity. It's a wonderful environment, a supportive group, and the ride leaders. So it was a great opportunity for me, as well as an opportunity for me to raise awareness and money.
But here's the thing, we're taking somebody of your prowess out of clinic, to raise money to do your own job. Why are we having to do this, Rob?
Well, I think it's interesting, isn't it? If we all had the right way to give money, then some of what's going on in the world today wouldn't be going on, and we'd be giving money in a different way. So I guess fundraising is always doing something different to raise awareness. Always has some role. Maybe the fact that I was doing it helped even more, in as much as I do this for a living and I can see the benefit, and so. It means so much that's why I did that. There might be nicer ways to do it, more where we give money the way we should give money as a society. But as long as we're getting the money and we're making the difference, and then I guess that's the most important thing.
And here at Q Leukemia, Rob, we are heavily focusing a lot of our fundraising efforts towards the Atticus network, and you being a key member of the team of Atticus. Can you give the viewers of the podcast a little bit more insight into Atticus?
Yeah, so Atticus is a trials network, and I think what's important for families, for children, for everybody, is to know these things, which is there are newer treatments. So if I look at kids, and actually put it straightly, kids that have died in years gone by, we have treatments that means we can stop those complications or cure their leukemia in different ways. So there are many new treatments, so many more. But new treatments need testing. So just because something looks as if it might work doesn't mean it actually does work, doesn't mean that it's as safe as we thought or whatever. So the way we test all new treatments is in a trial. And so that isn't an experiment. This isn't a guinea pig. This is a trial where we give kids new treatment because we're learning. It's good for everybody involved. It's good for the kids of the future because we're learning. And it's good for the kids of the current because they've got options to a treatment they would not otherwise have. And we wouldn't be giving it if I didn't think it was good. Mm-hmm. So we don't have to give it. If there's a new drug and we think it might help our kids, or a new therapy that we think might help our kids, then it needs a trial. And a trial needs money, it needs infrastructure, they're highly regulated, and so they should be. But to navigate trials and to get them open quickly and open across the country, there's no point me having a treatment in Manchester that isn't available for kids in Leeds, Sheffield, or Newcastle, or whatever. So, what we need is a national structure to open trials that we think are good and open them quickly and for kids all over the country. And that's where the Atticus network comes in, because at the moment we'll open the trial in each individual centre. That costs money, and that means that a company that has that drug or whatever may not open it in every centre because each centre will cost money. So let's open it centrally, and then we can all be part of that process. So it's cost effective, but it means that everyone gets it and we can open quickly. And actually we become attractive to companies, American companies, European companies, British companies that have a drug or whatever that we think is good. So, there's a virus called adenovirus, which is a problem after transplant. We've got a great drug. Mm-hmm. And we've opened the trial in Manchester, and we've opened the trial in one of the London centres, and we're trying to open it in different centres. But it isn't available for all kids across the country, even though it's just as serious wherever you are. So your option is either muddle along, and that's not always a great option, or you come to Manchester, and then we have to have a bed. So it's much better if we can open these things across the country together. And that's what Atticus is about. It is about those of us that look after children with leukemia and transplant kids with leukemia working together, having a collaborative network. More minds are better than one mind. If we all agree what's the right way, that's more likely to be better than just one of us thinking that. So it's about collaboration, it's about opportunity, and it's about using new treatments so that we can both learn for the kids of the future, but offer the therapies for the kids of today, so that we can bring those treatments to them and hopefully change their outcome as well as learning for everyone's future.
Do you reflect on your career and think if Atticus had been more developed in years gone by, there are patients that would have seen better outcomes.
Definitely. I mean, so I wouldn't be interested in a trials network if that wasn't the case, because I think we will change the outcome, not just for future kids, but for current kids. And if I look at where I've been this morning at the hospital and I've seen the kids in trouble, then, you know, there may be treatments for them that are coming through that I'm not giving today because we don't have the trials open. That is the reality of what we do. We get most kids better. Our treatments sometimes are toxic. Our treatments sometimes don't work well enough. And we live in a world where medicine is changing, especially hematology medicines. We've got newer treatments, safer treatments, better treatments. And so we have to put those two statements together, which is we have treatments and there is an unmet need, to use that word. So we're not getting everyone better. And the way to meet an unmet need with new treatments is a trial. And that's why a trials network is important. You know, when I look at how people donate their money for, you know, their charitable money or whatever, yeah, this is a bit different. This isn't about developing a new drug. It's not about developing a new treatment and or whatever. It's about enabling the trial of a treatment that is already there, that either a company has developed or we've developed in our own research labs. So it is about bringing a treatment that is present or available to the kids on the ward today, and that's enabling trials infrastructure. We need funding for our trials separately. We need the drugs and the treatments for our trials separately. But once we've got the drugs and we've funding, which is so important as well, we need to be able to deliver them. Otherwise, what was the point?
And this may seem like an obvious question, but we've spoken about centres in the UK. But what kind of global impact do you think the Atticus network could have?
I think the UK is a very scientifically literate country, and we've got we are significant. We look after a lot of kids. We sit within a world community, and we've got well-known hospitals and well-known developments. Some of our gene therapies, our CAR T-cell therapies, our transplant therapies are world leading, and you know, so a network that we deliver in the UK, the results of the treatments that we deliver to kids in the UK will inform practice across the world. There's nothing different about the way we look after kids with leukemia and transplant in the UK than in Germany or Italy or the US or whatever. So what we learn from a network in the UK informs practice across the world. And I think that's important. And it's something that we can do. And so if it's something that we can do, then it's something we should do.
And for those who are watching this podcast who think, you know, maybe my money should go towards Atticus, or maybe it's even a safer bet to put my money to see real results, what would you say to anyone considering supporting Atticus?
Well, I think that comes back a little bit to, for me, to the Tour de France, which is I do believe in this business of trials and trials networks. And so that's why I raised money for this charity. And that's why I rode the Tour de France for this charity, which is I do think that is a valid decision to make. It's one that I made. And there are lots of different charities and people will make their own choices. But I do think that this will make a difference, and that it's, you know, because it's a possibility and we know it will make a difference, it's something that we should do. And I think it will make a difference.
Do you feel like it's a responsibility?
Yeah, I think it is. I mean, I'm 60 now, and obviously, you know, wondering about when to, you know, retire and all of those things. And what I've learned at the bedside of kids is that I've seen kids where the treatments have worked, which is great. I've seen kids where the treatment is too toxic, that's not great. I've seen kids relapse after transplant or fail to go into remission. So there is unmet need. And that now is my motivation, is, you know, some of my own research work is directed at what I've seen. I've talked about cord blood. The reason I do cord blood is because when I look at the kids I've transplanted, personally, I see the results as better. If I see the results as better, then it's my wish to extend them, to understand them, and see if we can further improve them. And that is about responsibility. And so is the Trials Network, which is to leave and establish an infrastructure, a way of doing, which means it's easier for the people coming afterwards to bring these new therapies to the kids who are in the beds in the future.
And let me just pick up on that coming afterwards, because when you just mentioned retirement, I know you're not here to announce your retirement or anything like that, maybe. But there are lots of people who know you, trust you, think an awful lot of you, and put their faith in you. I guess I'm looking for some sort of reassurance here about the generation of haematologists that are coming after you. Have we got some great people who are ready to step into your shoes?
Oh, yeah. So I can. One of the nice bits about my job is seeing the very able young haematologists. So if I look at just in Manchester over these last years, then 6 or 7 actually young doctors have done a research degree with us and have then gone on into haematology, and they are very able young doctors. And if I look at people that have travelled to the Children's Hospital to become clinical fellows and not necessarily in the research labs, then I think 7 or 8 of them have gone into haematology training. And so I am confident in the future doctors that they are motivated, able, capable young people, and that they will deliver this trials network and deliver what it sets out to achieve.
And my next question, you're not going to like this, bit of a 2-part question, I guess. First part, do you think that you will still be spoken about in 20 years' time? But before you answer that, we've had lots of people on this sofa who have called you lots of different things. But the overwhelming title for you that we hear is that Professor Rob Wynn is a hero. How does that sit with you?
Well, we are very lucky in the work we do. I don't think, it's very nice. We are lucky in the work we do. I'm lucky to see sick children every day and their families, and to work with children and families when things aren't great, and for the majority to see them through that. As part of a team, it's definitely always a team effort. I think that's enough reward for me, is knowing that those kids are better and that they, and I'm not worried about legacy and things. I learned from some key doctors in the metabolic medicine, a guy called Ed Wraith, and I've mentioned Alan Burnett from Cardiff. If I can do to the other doctors what they did for me, that's an added privilege.
It goes back to you being that humble man that you are. What are you most excited about, Rob? Whether you are still actively involved in haematology or not, what are you most excited about for the next 5 to 10 years?
I think cell therapies. So using what we've learned about transplant, which is that the immune cells in the immune system can kill cancer, and seeing those cells be refined so that they can kill it more safely. So when we do transplant at the moment, the transplant kills the leukemia, but it can also cause something called graft versus host disease. So the graft attacks the leukemia, but the graft can attack the patient. And I think refining that, so we use the graft, the immune system, but instead of taking a risk of graft versus host disease, just get it to see the cancer. So that's things like CAR and other gene therapies, but also, the vaccine therapies and these things. And I think that this will change medicine in the next years, that we will increasingly use the immune system to kill cancer and to use it so that it's safer and more effective. Adults and children, solid tumors as well as leukemia. And I think in these last years, we've taken the first big steps into that immune cell revolution.
And recognising that every patient's blood cancer journey will be individual to them and different. What kind of message could you give to new families that are watching this podcast now? They've found the Patients Podcast because they're looking for hope, for support, for honesty and truthfulness. What could you say to those families now?
I think the first message for all families of children with leukemia is that most kids are okay and that we get through this together. It's not to say it's easy. It's not to say it's fair, because it's unfair. Why your child or what, and not, why have you been chosen? But the reality is that cancer happens, and the reality is, and particularly with blood cancer, we get most kids better, and that this is a changing area of medicine, that it's our responsibility to try and deliver those new therapies where they're safer or better than old therapies, and to deliver them as quickly as we can. And that's where trials come in. So I think, I go for me and for those families. I think those are the messages. Most kids are okay. And those promises that we will make the right decisions informed by previous trials and by evidence. We will do our best for kids, families and professionals. And we will always tell the truth. And the truth is most kids are all right. But the truth is not all kids are okay. And that we must work to close that gap of unmet need between curing all kids and curing most kids.
And Rob, we're so grateful that you've managed to take time out of your day to come and appear on the show today. What does the rest of your day look like? Because I know you've got to rush off straight from here back to the hospital, haven't you?
Well, no, thank you for coming. This is a cause that's very close to my heart. And so it's a pleasure to be here and to talk about my work and our journey together, including this Atticus network, because it's important for the kids that I look after. I've seen a lot of kids this morning, and I'll see those kids again this afternoon and their families. And we're having some meetings, discussions this afternoon about how to bring new therapies to the patients that need them, because we're all hurt by how slow this is. And some of that is about regulation, some of that is about arrangements for licensing and commissioning. And so, I've been at it a long time, and where we have treatments that work, we must look about how we get those treatments to the children that need it. I'm not interested really in getting nice papers in good journals and publications about a new treatment if we're not able to give that treatment tomorrow to a child in Manchester that needs it. And so some of being as old as I am now is about seeing where those blocks are and seeing if we can articulate and talk our way through them, not cutting corners, not doing things that are unsafe, but always trying to bring the treatments as quickly as possible to the kids that need them. And that's where Atticus is. If I look at the development of a new treatment from a concept like an idea through preclinical work in the labs, then the next phase is trials, and then more trials. So we have different phases of trial. But then at the end of that, we have an effective therapy that we need to bring to kids, and that's called commissioning. And so all of that, we need to look at that whole process so that we can make it quicker whilst keeping it safe, so that it's relevant to the kids in the beds today. So that's what this afternoon brings, is more of those discussions.
Well, Rob, I know I can speak for myself and for hundreds of other patients and families when I say thank you for what you do, what you have done, and what you continue to do.
It's very kind of you. Thank you.
It's been absolutely wonderful to have you on the sofa this afternoon, Professor Rob Wynn. Thank you so much. And thank you everybody for watching Let's Talk Blood Cancer, the Patients Podcast. We'll see you next time.